Welcome to this deep dive. If you're joining us today, you are likely a second-year medical student, right in the thick of your medical pharmacology courses, and today we have a very specific mission.
Right. Our goal is to get you looking past the textbooks and actually applying this pharmacology to real clinical scenarios. We are focusing on gout today.
Yeah, and I think gout gets, a bit of a bad rap in popular culture. People still picture it as this medieval disease of kings.
Oh, absolutely. The classic caricature of some wealthy royal eating too many rich foods at a banquet with a giant bandaged big toe.
Right, but that historical image does a massive disservice to what we now understand is a really complex metabolic and autoinflammatory condition.
It's actually a modern epidemic. It affects over 9 million adults in the U.S. alone. So, as future physicians, you need to know how to properly manage this.
Which is exactly why we're pulling from the 2020 American College of Rheumatology guidelines, up-to-date clinical reviews, and the Cleveland Clinic's dietary pathways for this deep dive. We want to show you the modern, multi-layered approach to treating it.
And to make this relatable for you, we are going to use a specific clinical case study from the sources. We're going to act as the medical team for a 58-year-old professor named TJ.
Let's establish TJ's baseline clinical profile first. So he's 58. He stands 5'11" and weighs 260 pounds.
Which places his BMI in the moderately obese category.
Exactly. And his medical history is notable for hypertension. Now, over the past 12 months, he has suffered 3 agonizing attacks of podagra.
Podagra being the clinical term for a gout flare specifically localized to the big toe. It is the classic presentation you will see in the clinic.
And his recent laboratory workup shows a serum urate level of 7.5 milligrams per deciliter. So let's talk about the mechanism here.
Right, because to understand the attacks, you have to evaluate that 7.5 level. Hyperuricemia is simply an excess of uric acid in the blood.
Which is just a waste product, right?
Yes, it's the terminal waste product of purine metabolism. Normally, it just circulates and your kidneys excrete it. But when that 7.5 threshold is breached, the uric acid actually precipitates into monosodium urate crystals.
The MSU crystals. And they have this sharp needle-like shape that deposits right in the joints.
Exactly. And your innate immune system recognizes those crystals as a threat. Macrophages try to clear them, which triggers a massive inflammatory response.
But we should clarify for everyone listening, hyperuricemia is necessary, but it's not sufficient to cause gout on its own.
That is a crucial point for your exams and your practice. Many people walk around with high uric acid and never get a gout flare.
But for TJ, obviously that threshold has been crossed. He's had 3 flares in a year.
So he has transitioned into active disease, which brings us to phase 1 of his management, putting out the fire.
Right. TJ wakes up, his toe is swollen, red, throbbing. How do we treat the acute flare?
The ACR guidelines outline 3 first-line pharmacological options for this: colchicine, nonsteroidal anti-inflammatory drugs, or glucocorticoids.
NSAIDs or steroids. But here is where we have to look at the whole patient, not just the toe.
Exactly. What's fascinating here is how his comorbidities dictate our prescribing strategy. TJ has hypertension.
So if you give him NSAIDs or systemic steroids,
You're asking for trouble. They promote sodium and water retention. That can acutely elevate his blood pressure and totally interfere with his current blood pressure medications.
so they are basically too risky for him.
They are. Therefore, low-dose oral colchicine is the safest and most appropriate choice to abort his flare.
And I want to highlight that you said low-dose colchicine. The guidelines really emphasize this over the old high-dose method.
Oh, the paradigm has completely shifted. The historical approach was basically dosing colchicine hourly until the patient developed severe gastrointestinal toxicity.
The old dose-to-diarrhea method.
Exactly, which is awful for the patient. We now know that a low-dose regimen gives the exact same pain relief, but with far fewer severe adverse GI side effects.
Okay, so the flare is managed, the toe feels better. Now we move to phase 2, uncovering the hidden triggers.
We have to prevent the next attack by looking at his daily habits, and that starts right in his medicine cabinet.
Let's unpack his hypertension regimen. He takes 50 milligrams of hydrochlorothiazide daily.
Which is a thiazide diuretic. And as pharmacology students, you should immediately recognize the problem here.
Thiazides actively decrease the renal clearance of uric acid.
Yes, they essentially force the kidneys to hold onto the urate, causing it to build up in the blood. So his own blood pressure medication is actively perpetuating the conditions for crystal formation.
But we obviously can't just take him off his blood pressure meds.
No, but the ACR guidelines conditionally recommend a very elegant solution here. We switch his hydrochlorothiazide to an alternative called losartan.
Losartan is an ARB, an angiotensin II receptor blocker.
Right, but losartan uniquely possesses a uricosuric effect, meaning it actively helps the kidneys excrete uric acid.
So by making that one single medication switch, we treat his hypertension while simultaneously lowering his serum urate.
It's a perfect pharmacological 2-for-1.
Okay, phase 3, the dietary minefield. We need to look at what TJ is actually eating every day.
The Cleveland Clinic and up-to-date sources are very clear on how diet drives this pathology. Let's hear TJ's typical intake.
All right, he has granola with honey for breakfast, poor boy sandwiches with heavily processed meats or shrimp for lunch, large dinners with meat and vegetables,
Okay.
and it gets worse. He eats 50 different flavors of Bluebell ice cream, drinks 2 to 3 cans of Coca-Cola Classic, and has 3 to 4 beers every single night.
Wow. Okay, so you need to dismantle this diet systematically. Let's start with the purines.
The shrimp and the beef.
Right. Those are packed with purines, and your body metabolizes those purines directly into uric acid, so he is just dumping raw material into his system.
And then there's the alcohol. Beer is specifically highlighted in the sources as a major issue.
Beer is actually a double threat for gout. First, it is high in purines itself. But second, when your liver metabolizes the ethanol in the beer, it creates lactic acid.
And that lactic acid directly competes with the uric acid for excretion in the kidneys.
Exactly. The kidneys prioritize clearing the lactic acid, which actively prevents them from clearing the uric acid. It just gets trapped in his blood.
So the recommendation there is a hard stop on the beer.
Yeah.
Switch to herbal tea, or if he really wants alcohol, maybe 1 to 2 glasses of red wine at most.
Wine doesn't seem to trigger the same extreme hyperuricemic effect, but we also have to talk about the fructose trap, the Cokes and the ice cream.
Right, they're loaded with high fructose corn syrup.
And fructose is incredibly uricogenic. Fructose metabolism breaks down in a way that directly generates uric acid, completely independent of the purines he is eating.
So if we use an analogy here, TJ's diet is basically like turning on a massive faucet of uric acid with the purines and the fructose.
While simultaneously plugging the drain with the beer and his diuretic medication, that is a great way to visualize it for your exams.
But phase 4 is realizing that diet and medication tweaks aren't going to be enough for TJ.
No, they won't. He has had 3 flares in a single year.
And the ACR guidelines are definitive here. Having 2 or more flares a year is a strong indication to initiate pharmacologic urate-lowering therapy, or ULT.
Right. And the preferred first-line agent for ULT is allopurinol. It's a xanthine oxidase inhibitor that stops the body from synthesizing uric acid.
But if we connect this to the bigger clinical picture, the strategy isn't just handing him a prescription for allopurinol and sending him home.
Definitely not. You have to use a treat-to-target strategy. The goal is to drive his serum urate down to a specific target, which is less than 6.0 milligrams per deciliter.
Down from his current 7.5.
Yes. You start him on a low dose, maybe 100 milligrams a day, and you gradually titrate it up based on his lab results until you hit that target.
But this brings up a massive paradox that you absolutely have to warn your patients about.
The mobilization flares. This is the biggest hurdle to medication adherence in gout.
Initiating allopurinol can actually trigger an acute gout flare.
Exactly. When you rapidly lower the uric acid in the blood, you destabilize the existing crystals in the joints. They start to shed their protective protein coating.
And the immune system suddenly sees them again and attacks.
Right. And if you don't educate the patient about this, they will take the allopurinol, get a massive flare, assume the drug is making them worse, and throw the bottle in the trash.
So how do we prevent that? What's the prophylactic shield?
We use the exact same drug we used for the acute flare. TJ must concurrently take low-dose colchicine every day for 3 to 6 months while the allopurinol takes effect.
So the allopurinol handles the long-term cure, and the colchicine prevents the short-term flares while his body adjusts.
Precisely. Now, I should mention, for your pharmacology knowledge, there is another option for incredibly severe refractory cases.
The patients with massive tophi, those huge chalky uric acid deposits.
Yes. For those end-stage cases, there is an IV infusion called pegloticase. It is a recombinant uricase enzyme that actively dissolves the crystals very rapidly.
But TJ is nowhere near needing an IV biologic.
No, thankfully we caught him early enough.
So let's summarize the comprehensive clinical plan we've built for TJ.
First, acute flare management with low-dose colchicine to protect his blood pressure.
Second, switching his hydrochlorothiazide to losartan to get that uricosuric benefit.
Third, massive lifestyle modifications. Cutting the purines, eliminating the high fructose corn syrup, and stopping the daily beer intake.
And finally, starting allopurinol on a strict treat-to-target protocol, shielded by prophylactic colchicine for the first few months.
It is a delicate balancing act of pharmacology, genetics, and lifestyle. But the main takeaway for you as future providers is that gout is a highly curable disease if you manage it comprehensively.
It really is. I want to leave you with a final provocative thought to ponder as you study this week.
What's that?
Well, think about the global rates of obesity and metabolic syndrome right now. They are absolutely skyrocketing.
That's true.
And our modern food supply remains completely saturated with high fructose corn syrup and processed foods. So are we unwittingly engineering a massive resurgence of this ancient disease?
It's a sobering question. Could gout soon shift from being just a historical punchline to the defining joint disease of our modern era?
Something for you to think about. That wraps up our analysis of gout management for today. Thanks for joining us on this deep dive.